welcome to our series on the 21st century modern medicine, its practice, its miracles, its problems. My name is Maru Walliser. I am co-chair of the Adult Lectures Committee for the Adult School. And I have to tell you that one of the corollary pleasures of working on this committee is the opportunity to introduce individuals for whom I have had a long and deeply felt admiration. That's usually because the work they have done over the course of life and career has really made a significant change, a difference in other human beings. Tonight's speaker is one of those people. A scientist, a medical doctor, a wife, mother, and grandmother, and a community member who has cared for and advocated for the health of all of us, as well as for those less privileged than many of us in this audience. She was my own primary care physician for many years, a compassionate, open, and totally present physician when I saw her in her office. But she was also interested in much more than my medical needs. We talked about the wonders of the American West because she grew up in Oregon and I spent summers in the Colorado Rockies. We talked a little, but not too much, about politics. We even discussed the preparation for her son's wedding in India. When she decided to close her private practice to devote time to being director at the hospital of the new outpatient clinic for low-income residents, I was truly distraught. Yet this was so in tune with her values and her character that I had to admire that too. And before she left the practice, she took great care to see that each of her patients, including me, was placed with just the right physician. How could I not be grateful for that kind of care? Margaret Lansfield, our speaker this evening, graduated from Harvard when part of it was still Radcliffe, with a degree in biology. She went on to the University of Pennsylvania to earn a PhD in micro as well as molecular biology, and she did postgraduate work and teaching at Cornell before joining the biology department at Swarthmore, where she became chair of the Division of Natural Sciences. There she also met and married another faculty member, someone also familiar to many of us, Rush Holt. That union survived, as she says. It survived her decision to go to medical school at Yale, followed by a residency in internal medicine at Penn, and her work at Robert Wood Johnson Medical School. Board certified in internal medicine, Dr. Lansfield was Associate Professor of Medicine at Robert Wood Johnson, now Rutgers Medical School. When Professor Holt became assistant director at the Plasma Physics Lab here in Princeton, they moved, and she became a practicing internist at the University Medical Center, a position of which I and many others were beneficiaries. As director of the University Medical Center at Princeton's outpatient clinic, Dr. Lansfield has led a clinical effort that cares for over 7,000 low-income residents in our area. And it is now sponsored by Bristol Myers Squibb over there. If you've been over at the new hospital, you've probably seen it. She says she retired in 2015, but it's been a slow process and she's still doing a lot of things. Dr. Lansfield and her husband, now former congressman, have 3 grown children and 7 grandchildren. They live both in Washington, D.C., where Rush is CEO of the American Association for the Advancement of Science, and at their home in Hopewell, where she gardens, raises chickens, and cuts wood, which her husband splits to stock their wood stoves. Who is it that said that women can't do it all? I think she's local, but I'll talk to her. Tonight, she will give us a modern doctor's perspective on the remarkable developments in the practice of 21st century medicine. Please give a warm welcome to Dr. Margaret Lansfield.
these last few weeks kind of thinking about what I wanted to tell you about healthcare. But I think, so I decided I was going to talk about the ever-changing knowledge about human health and the practice of medicine here in the U.S. over about the last 100 years or so, and how we pass this knowledge on to train new physicians, and how the pace of change and the complexity of change is just accelerating to the point that today we're all kind of holding our breath. And this, of course, is from my perspective as an internist, teaching and practicing roughly the last 30 years or so. What's going to follow in the weeks to come is a really fine roster of people who are going to speak to you about, in much greater depth than I can, about some of these challenges that we're facing today. You're just going to, I think, really enjoy every one of them. I've been really lucky to be able to teach and practice at a time when so much was already known. There was a lot that we could do to help people, and there wasn't quite so much 100 years ago. And also, at the same time, when some of the personal or more traditional aspects of medicine were still possible, and I hope they will continue to be possible in the future, but it may take some work. Medicine is a really exciting science. It's always advancing and retreating by fits and starts as our knowledge of the human body, pharmaceuticals, and technology keep moving along. I also really firmly believe that medicine is also an art that can be learned. It isn't always learned, but it can be learned. It's an art where listening, warmth, sympathy, coming to get to know a person, understanding their situation, I believe that actually has real healing powers. And often the patient is not just one person cared for in isolation, but is part of a family and a community. And they're all affected by this illness. And I think in many cases, this true healing, we need certainly all the science, but we need the art too. So in the 1930s and 40s, when my father was a country doctor in rural Oregon, he did everything. He delivered babies, every single one of my friends he delivered, removed that inflamed appendix, set broken bones, sewed up deep gashes, and talked to that troubled veteran home from the war with what today we would call PTSD. He treated the young and the old in his office or in the hospital or with a house call in the middle of the night for an emergency, maybe a heart attack or a stroke. During his career, knowledge, medications, technologies advanced quite a bit during his career. And as that came along, doctors began to specialize more and more. All the surgical specialties, psychiatry, obstetrics, pediatrics, internal medicine, until right up to today, when there are specialists for every single body part or organ, and ages from the very, very young to the old. I would sometimes joke that if you had a problem with your knee, you needed to be sure that you knew whether you went to a right knee doctor or a left knee doctor. For me, I went to medical school already with a pretty solid knowledge of biochemistry, molecular biology, and so on, and experienced in teaching, and passionate about learning how to apply the science of medicine of the day to the whole person. Naturally, I became an internist. To do that, I needed to learn and develop the art of medicine while keeping up with all the science. I didn't know it when I started, but I learned along the way that if I was going to be effective at helping people, sick or well, I needed to know about the complex, ever-changing insurance systems, or lack thereof, found in our community. And much of the time, I needed to explain it to my patients and their families, and sometimes my colleague physicians, and advocate for my patients. So when I started practicing medicine about 30 years ago, there was a lot available. Think of the vaccines we had and why people are shunning them today. I have no idea. We had vaccines for rabies and smallpox, influenza, yellow fever, typhoid, measles, mumps, rubella, diphtheria, tetanus, meningitis, pneumococcus, and da-da-da-da-da. We had a lot of vaccines. And we had antibiotics. The list wasn't all that long, but they were really good antibiotics. The first were sulfa, but then the penicillins and the cephalosporins that came from them, and the mycins, the erythromycins, and just as I was starting, these quinolones were coming along. There was a pretty good bunch of antibiotics. And the pharmaceuticals, we had quite a bit of that too. We had insulin, we'd had that for quite a while. We had some medicines for high blood pressure that had pretty awful side effects, but we had them. There was general anesthesia for surgery, morphine, pain medicines. We had some psychiatric medicines to help with psychosis, anxiety, depression. We had already had medications to suppress rejection of foreign tissue, allowing kidney transplants. And the FDA had already been around for 70 years, trying to define and enforce standards of safety, efficacy, and quality control on prescriptions. There's still a lot of need for that. And the technology wasn't too bad either. We had x-rays and CAT scans and ultrasound and early MRIs. There were breathing machines, respirators, heart-lung bypass machines allowing pretty complex heart surgery. There was kidney dialysis. We had techniques for harvesting and storing all kinds of blood products that could be used along the way. So I had a lot. It seemed pretty good. Medical education, that was important to me because I was a teacher, knew I was going to continue to be a teacher. Medical education hadn't really changed very much from the early years after the Carnegie Corporation funded Abraham Flexner in 1910 to study and establish standards for medical schools, requiring a standardized curriculum, ultimately with testing and licensing of physicians and hospitals. You may recall Abraham Flexner also founded another famous institution here in Princeton, the Institute for Advanced Studies. The first 2 years of medical school were didactic courses in anatomy, physiology, things like that, followed by 2 years of hospital-based, really, apprenticeship. Apprenticeship-like training with someone like me in charge of a group of students, interns, and residents. So the training was really, and still is, almost exclusively hospital-based. So there would often be half a day or maybe a whole day of an office experience, but it was hospital-based. Medical schools were in larger cities, sometimes affiliated with VA hospitals or charity hospitals funded by city taxes and philanthropy. The hours were long. The patients were poor or veterans. Patient hospital stays were days to weeks for testing, treatment, and following the course of a disease. Medical schools in not so large cities had relationships with smaller community hospitals, such as Princeton, to have access to enough teaching material. Early doctors practiced as solo physicians, occasionally in small groups, and they were paid a fee for each visit or service or procedure, or paid in kind, sometimes, like my father. I still remember those, I don't know how many pounds we got. It was 40 or 50 pounds of elk meat. And this elk had lived way, way, way too long. And my brother and I swore it was just like eating old shoes. And we ate every bit of it. Insurance plans grew slowly out of dangerous work in 3 professions: construction, steel factories, and shipyards. OSHA wasn't around yet. Large numbers of workers became ill or disabled or died, In 1907, roughly 10% in those three fields I mentioned. Some companies started to provide a little bit of emergency care, just for the worker, never the family. One of the earliest prepayment insurance systems started in the 1920s in the Mojave Desert in California, where workers were building the Colorado River Aqueduct. A 12-bed hospital was built for injured workers, but nearly went bankrupt because the workers couldn't pay to be in the hospital. And so a rather forward-thinking physician thought maybe he could get the employer of these workers to prepay for some insurance should something happen to the workers. And the prepayment system started, 5 cents a day for workers to be covered for their injuries, 10 cents a day, prepaid ahead, for non-work-related illnesses. The families weren't covered. The hospital became successful. Later, supported by an industrialist named Kaiser, workers were building the Grand Coulee Dam. And even later, shipyard workers during World War II were covered by their Kaiser employer-based insurance. At the end of the war, the shipyard shut down and workers became uninsured. But Kaiser and others with him thought maybe they could open this insurance program to the public. And that really was sort of the beginning of more general insurance for the public. And of course, Kaiser Permanente is still a very big functioning system, more in the West than the East, but they're here too. Even so, in 1940, only 10% of people in the US had any kind of health insurance. Health insurance really took off during World War II due to wage controls imposed by Congress in response to rising inflation. It was deemed that health insurance was not a wage and therefore was not taxed. The employers liked this. They did it en masse as a way of trying to attract employees. And having this employer-based health insurance simply became part of having any job long after the wage controls were gone. This insurance was based on a fee-for-service kind of schedule for hospitals as well as doctors. It worked great until the rising number and cost of medications and technologies and doctors and the absolute lack of incentives to curtail costs led employers to cut back on benefits. And as recessions came along, workers lost jobs and their health insurance. And an additional problem developed as people lived longer and retired. The elderly had no health insurance. So in 1965, it sounds like they did it in a snap. They'd been talking about it for 40 years. But in 1965, Congress approved Medicare, a federal program for the elderly, and along with Medicaid, a federal state program for the poor. As time has gone by, Medicare reimbursement, which is set by the federal government, and particularly Medicaid eligibility and reimbursement rates, which are set by the individual states, have failed to cover completely the cost of care. Furthermore, the move to the suburbs by the more affluent and the falling tax bases in larger cities has led to the closing of charity hospitals. I'm not sure whether there must still be some large city with a charity hospital. I'm not sure about that.
New Orleans.
Now, well, that one went down with Katrina. Yeah. In 1980, a CMS, which kind of works with Medicare and Medicaid, changed hospital Medicare reimbursement from a fee-for-service plan to DRGs. DRGs are diagnosis-related groupings that pay a fixed amount for a specific diagnosis or illness, no matter how long a patient is in the hospital or what tests and treatments are given. This was an effort to incentivize cost-efficient care in the hospitals. Although hospitals today are usually paid these lump sum DRG amounts, depending on what the problem is, most physicians are still paid according to a fee-for-service schedule, creating mismatched incentives for hospitals and doctors. In 1986, Congress passed EMTALA. I won't even tell you, E-M-T-A-L-A. It's an anti-dumping rule. We need to have it. It's an important one, requiring that all hospitals care for any patient who comes to their emergency room with a medical emergency, so that they can't just be put in an ambulance and sent on, if they don't have insurance, to some other hospital. So that's kind of all of that about where things were with the insurance and the science and everything and what we know when I started. And I've really loved my practice of medicine these 30 years. I've seen a lot of change and I expect more, even faster. I can assure you, even as I go through some of these changes we're going to talk about, that I did not retire out of frustration. I found the learning along the way challenging and stimulating. I miss it, and I would definitely do it all over again. So here are some of the things that have come along in my 30 years. Pharmaceuticals. So we have much better medicines for blood pressure and diabetes. Potent medicines to block too much acid production in the stomach. They've been in the news recently. Cholesterol-lowering medications, treatment for osteoporosis, lots more help with epilepsy, mental health problems, addiction problems, lots more antibiotics, but very few of them are really new. And several antifungal and antiviral medications. We know HIV and have changed it. When I first started practice, we knew what it was, we knew what caused it, and it was a fatal disease. And then we got to the point where we could control it longer, but you had to take 15 or 20 pills a day at different times, some on an empty stomach, some not. And I mean, you just had to spend all day long keeping track of all of these pills. And now, in the right situations, we're down to 1 pill a day, and people with HIV live as long as anybody else. We can cure hepatitis C, and we have 2 vaccines that prevent cancer. One caused by hepatitis B, and another by the human papillomavirus. We have better treatments for asthma and emphysema, heart attacks and strokes, and really potent clot busters. And there have been absolutely phenomenal advances in cancer treatment. At first, we could only go after cancer cells with poisons that had a slight preference for cells growing a little bit faster than our own cells. Usually made us pretty sick along the way and sometimes killed us. From genomics today, we can fingerprint a person's unique cancer, follow it as it changes over time in response to our treatments, and deliver targeted drugs to stop it or to stimulate our own body's immune system to go kill it. And with an exciting new gene product called CRISPR-Cas9, I know someone's going to be talking about that later on, we can replace a defective gene in research animals or cultured human cells. We're getting close to being able to cure some genetic diseases such as muscular dystrophy or maybe cystic fibrosis, and maybe even design our future children. Many of these treatments are extraordinarily expensive, and the possibilities of CRISPR-Cas9 raise important ethical questions. I'll talk a little later about some of the costs of these, and I know we have a speaker who's going to talk about ethics, and I'm sure you're going to hear more about that. The technology, it's amazing what's come along in my career. So MRIs have gotten really good. We have PET scans, stents, less invasive laparoscopic and now robotic surgeries. We have fancy pacemakers to control heart arrhythmias and defibrillators that can save a person's life. There are deep brain stimulators that can help treat Parkinson's symptoms. We can transplant livers, hearts, lungs, sometimes the pancreas. 3D printers and other technologies are changing prosthetics. And of course, there are huge changes with computers. The old paper chart in the hospital or doctor's office is vanishing. There is a real potential, and I want to stress potential, it's not here yet, for our health records to be available to us and any doctor in the US or around the world instantly. Patients can be monitored at home. They can have virtual appointments with a doctor. And a neurosurgeon might be able to operate robotically on a person thousands of miles away. Already in Princeton, critical x-rays taken in our emergency department late at night can be read by our radiologists at home or in another country. These pharmaceuticals and technologies and some physicians' fees have led to greatly increased costs. And if applied universally, would bankrupt any country in the world. All of the developed countries are struggling with this. With this progress has come increased life expectancy, straining Social Security. We'll hear debates about that. Healthcare has moved from treating an acute illness, for which one either fully recovers or dies, to managing patients with costly chronic conditions. The costliest 1% of Medicare patients cost $146,000 a year. This amounts to 14% of all Medicare spending. These patients average, these costliest 1%, 8 chronic conditions. Some of these could be high blood pressure, high cholesterol, kidney disease, heart disease, asthma, emphysema, degenerative joint disease, mental illness and addictions, and dementias. Furthermore, 95% of the $1 trillion spent on healthcare annually in the US goes to direct medical care. But 60% of preventable deaths are rooted in modifiable behaviors, such as smoking, obesity, arguably addictions, diet, exercise, lack of transportation, and environmental exposures, bad air, lead in the news recently, asbestos, guns, violence, elder and child and sexual abuse. It's all of this that is stimulating CMS, again, that works with Medicare and Medicaid, insurance companies, legislators, policy analysts, to try to find incentives for doctors, hospitals, community support groups, and the public, us, to work together to make it possible to care for everyone. Can we find ways to make the right diagnosis, provide the optimal treatment in the right place, economically, and broadly educate the public and support community providers to change unhealthy lifestyles and make living and working environments safe for all? Experiments to achieve these goals are underway. Some of the most recent ones supported by the Accountable Care Act. There are experiments funded by CMS for private practice groups using the power of electronic data collection and communication to identify quickly the costliest Medicare patients in their practices, to pay the private groups upfront with funds to integrate and coordinate care among generalists and specialists, pharmacies, home care nurses, social workers, physical therapists, mental health providers. In some cases, even support community groups to provide transportation and other social services. The more money saved with this integrated care compared to a similar control group of Medicare patients, the greater the financial reward for the physicians who have put this all together. An interesting experiment. Similar trials are also being carried out by private insurance companies. There are financial rewards by CMS and insurers for what's called value-based care, and penalties for lack of it. such as offering flu shots, achieving blood pressure goals, or controlling diabetes in patients. There are incentives to patients by insurers for them to get flu shots, to join a gym, to fill their prescriptions for their blood pressure, diabetes, cholesterol. There's similar experiments like these going on in clinics and hospitals that care for the uninsured and the underinsured. When I say underinsured, I usually mean Medicaid. That's the largest group of people who, quote, have insurance, but it doesn't go very far. Here it's not so much that if these experiments are successful, that the clinics and hospitals will make more money. It's rather they will lose less. These experiments have resulted in practices and hospitals hiring healthcare extenders, physicians, assistants, nurse practitioners, social workers, all to help coordinate all this care. There are also experiments to provide incentives to hospitals and doctors to work together. DRGs covering all hospital expenses in a single stay, I mentioned that before, have been present for years, but now there are efforts to include the physicians in the bundled payment, hoping to control unnecessary fee-for-service visits and lengthy stays by unneeded specialists and doctors during a stay. And to try to improve the quality of care, there are financial penalties to hospitals who have too many avoidable readmissions. It's quite possible, as these experiments in different reimbursement models proceed, we will learn that as a country we have too many specialists, or at least a maldistribution of specialists, especially in larger cities, and too few primary care physicians. If so, this will take time to fix. Only 1/4 to 1/3 of practicing physicians are in primary care fields in the US. And many of them are retiring early, frustrated with keeping up with all these experiments and changes. Others are aligning, that's the word that's used in the industry, are aligning with hospitals and hospital practices, own practices, and becoming salaried. Furthermore, the high cost of medical school, whereby the average debt on graduation is about $200,000, many medical students go on to specialize in the much higher paying, and I will say at the moment, specialties in order to pay off their debts. And so there's not so many going into primary fields yet. So I want to talk about two movements. Any of you who have been yourself or had a family member or a friend recently admitted to the hospital will be aware of these two movements. The first is what's called the hospitalist movement. This started more than 15 years ago in some parts of the country and arrived in Princeton about 10 years ago, I think. It became harder and harder for primary care internists and pediatricians to have time in their very busy office schedules, as well as their lack of the newer, ever-changing, highly specialized knowledge to care for really sick patients in the hospital on a moment's notice, 24 hours around the clock. Other developed countries have had specially trained hospitalists who only work in hospitals and teams and provide around-the-clock care. This model is now really, that's what it is in the United States. It has its strengths and weaknesses. Hospitalists don't know the patient over time or the patient's family. And sometimes they're so busy they don't have time to communicate with the patient's primary care provider and many specialists in the community. The patient and his family have never met the hospitalist or his rotating team. Unless there is an information technology system tightly integrated and easily accessible among the community physicians and the hospitalist may have great difficulty learning the patient's relevant history or even what medicine he's actually taking. And when the patient leaves the hospital for rehab or home, confusion about medications and follow-up can happen quite easily, resulting in readmissions, sometimes costly to the hospital. These problems, they're not insurmountable, but they really do require some very diligent work. The other movement I'll talk about is something called observation. This is another cost-saving program initiated by CMS a few years ago. There are many very appropriate illnesses for which people go to an emergency room. Many of these are self-limiting, such as that awful, miserable GI bug with vomiting and diarrhea that needs some IV anti-nausea medicine and some IV fluids. Perfectly reasonable. You should go to the emergency room if you've got it bad. Most of the time, the emergency department stay is 4, 5, 6 hours, and things are under control enough you can kind of crawl home and be okay the next day. But if that's not adequate, in the past, these patients were admitted to the hospital, and they would go home 1 or 2 days later. Very commonly, patients have episodes of chest pain. Very appropriate to come to the emergency department, where physicians need to quickly diagnose a heart attack in progress, or to prove that the patient is not having a heart attack, or not just about to have a heart attack. This ruling out process, as it's called, takes somewhere from 12 to 24 hours. Too long to stay in the very, very busy emergency department. These patients used to be admitted to the hospital for a day or so. In both of these examples, patients are moved from the emergency department to a hospital bed. But under observation, technically, the patient is not admitted to the hospital. He's admitted to observation, for which Medicare pays the hospital and bills the patient as if this were an outpatient office visit. A rather complex one, but nevertheless, it's using Part B of Medicare rather than Part A of Medicare to cover this observation stay. Of course, if the patient isn't better in 24 hours, or is actually about to have a heart attack, the patient is converted from observation to an inpatient, perhaps in the very same bed. No wonder this is really confusing. And in spite of a recent story heard on NPR about observation status, suggesting that the patient or his family simply ask the hospitalist or private doctor just to make the patient an inpatient, that doesn't work well. Both the hospital and the doctor can be penalized. So with all this change going on, how have I managed to incorporate the art of medicine into the hospital and office-based teaching over the years? I thought I'd end with just 2 stories about 2 patients of mine. I could go on and on with more stories. Let me tell you first about Mr. R. He became one of our clinic patients after a hospital admission. I first met him when I was in charge of his team of medical students and residents in the hospital when he nearly died from a gangrenous gallbladder. He waited too long to come to the hospital. He didn't have insurance. He didn't speak English very well, and by the time he got to the hospital, he was in really big trouble. He was gravely ill. He was in the hospital for weeks and had just about every complication I could imagine, and a few I couldn't have. Ultimately, he went home on a lot of pills. He always came afterwards to his clinic appointments, where we had many Spanish-speaking staff. The medical resident who worked with him every time he came couldn't understand why his blood pressure and his diabetes weren't getting any better. He kept prescribing more pills, adding more, changing doses, nothing seemed to work. Then he had the really smart idea of having the pharmacy write the directions on his medicine bottles in Spanish. And we called the pharmacy to be sure that he was picking up his prescriptions. He was. So we got them in Spanish. He was picking them up. We asked him, and still his blood pressure and diabetes wasn't getting any better. So we said, bring in your bottles, which he did. There must have been 15 of them, maybe 20. Some were older prescriptions he'd been told to stop, some with instructions in Spanish to take before breakfast or after breakfast or before bedtime or with dinner. And he showed us how he took one pill from each bottle every day. Well, this led to a conversation assisted by a translator about where he had grown up and what it was like when he was growing up. Well, we learned he'd had only 2 years of formal schooling, and he was illiterate in his native language. Since then, we arranged for him to stop by the clinic monthly with his bottles. Our nurse would check his chart for any medication changes or prescription refills that were needed, and would fill 2 pill dispensers for the morning pills and the evening pills. He took them regularly. By a few weeks later, really it took 2 or 3 months because we kept cutting back on doses and using less and less and less, because it really took very few pills to help with his blood pressure and his diabetes once we were all on the same page. The other one I want to tell you about is Mrs. S. She was an elderly woman brought to the hospital late at night from her nursing home, curled up, barely speaking, dehydrated, with a fever, and what seemed like a kidney infection. I met my team early the next morning, and I asked about the roster of our 5 admissions overnight. We would see them all. I always liked to spend a little extra time teaching if there was one particularly interesting case. I was told there were no interesting cases. They were all elderly patients from nursing homes with various infections. And Mrs. S was absolutely the worst. She just mumbled about a rocking boat. So I decided we would see the least interesting case first. As I pulled up a chair by her bed, she looked frail and unwell and was mumbling about a rocking boat. But as I took her hand, she opened her eyes, acknowledged me as I introduced myself and our team. "Tell me about the boat," I said. "Oh," she said, "it was the Titanic. You know, it sank." Over the next couple of days, as we treated her infection, she told us about her childhood and how she was on that boat, that fateful boat, and how she and her mother survived. My team learned to sit at eye level and spend a few moments getting to know the patient. Thank you. And I'm happy to thank you. Yes.
What are the next progressive steps do you see happening on our way to Star Trek medicine?
Well, it's really it's a huge question. We will find ways. I'm the eternal optimist. We will find ways, I think, to provide quality care in some affordable way for the vast majority of people in our country. Maybe not everyone. I would like to see everyone. I mean, we're working on it. And it sounds kind of brutal at the time, but we will get there. And the informatics, the technology, the computers will play a big part of that. the Star Trek side of it, in a way that this, you know, for me, the almost scarier part is, you know, we do die. And so what is that going to be like? Are we going to live with all of this, you know, not demented, active and feeling well, and then suddenly not? Or are we going to face, you know, just terrible, terrible challenges of what I kind of call not being alive or dead? And how are we going to pay for that? So that's another aspect. And then CRISPR-9, Cas9. I mean, so what kind of human race, how are we going to handle this question about, I mean, so far they've decided in this country that you cannot do these experiments on human embryos. But I don't know where that's going. I mean, it might be wonderful, you know, to be able to, you know, if you know, carry the genes for Tay-Sachs, to be able to fix that embryo and have a normal child. But what happens if we want, you know, we want them blonde and so tall and football players or pianists, or, I mean, where are we going to go with that? I don't know.
The question is actually the opposite. From your father's practice, looking at people in their final years, what was the best of what you saw that you was doing with them that was better than what we did?
I think we are do and are capable of doing what he did too, which is whenever there isn't anything more that we can do to help whatever, and is one relieves suffering, provides comfort. He did that. We do that today too. Do we always do it? Absolutely not. And there are too many horror stories of weeks in intensive care units, hooked up to machines, in kind of situations that cannot possibly get better, that you know, we don't always do it, but and I think David Barilli is one of the people who's going to be talking, and he will be talking about end-of-life care, and there is a lot that we can do today, and do. Sometimes we don't hear about it. And people have different, not everybody wants the same thing, so that's the other piece of it. It's why you need to know somebody, have some time, hopefully before bad things start to happen, to kind of have conversations about what people want. Yeah.
I just retired from Indians in higher education, and what I saw over time was a fascination with data, and to the point where I feel as though whether it's healthcare or education or whatever, fascination with data obscures the individual, and
Yeah.
data can be very useful, but it has to be in service
Right,
of.
right, in service of. I'm not sure everybody heard that, and I can't agree with it more. The observation that there's just an increasing fascination with all the data that we can collect, and that it's sometimes at the expense of connecting with the human being. I would sometimes, I mean, I know it happens in hospitals that doctors will sit there at a computer, there's a call, there's this patient who's come in, and they look and they see what the x-rays and the EKG and the laboratory studies order, and without even walking into the room and seeing the patient, they sit at the computer and start writing orders. And I think that's a mistake. I don't think it's insurmountable, but we're gonna have to work at it.
People who are practicing medicine have to be willing to try to surmount it.
Yes, they do. So we need great teachers. Yeah, yes.
I was wondering, when you talked about the hospitalist movement, whether you saw the American Board of Medical Specialties moving toward board certification of hospitalists, or whether you think the current boards, pulmonologists, nephrologists, and all these people are simply going to practice in the hospital, some of them, and be hospitalists within their own currently recognized field? Or are they about to board certify hospitalists, period?
Yeah, at the moment, and a little bit, I've just seen the hospital movement as it's kind of rolled out in the eastern United States, and I think it's further advanced in the West, but they're not very close yet to board certifying it. And often, I see that residents who finish a residency in pediatrics or internal medicine, but particularly those two fields, haven't decided whether they want to go on and do a specialty, additional training in a specialty. So they take a job as a hospitalist. Remember, their training has been almost exclusively hospital-based. They are really up and current on how to handle these quite sick people. So it's kind of a natural for them that they go and take a job as a hospitalist, sometimes for just a few years before they kind of burn out from it. Or they then go on and do a specialty, or they leave the hospital side of medicine and then start practicing an office-based thing or whatever. Yeah, so it could certainly come to that. I mean, we already have essentially we have intensivists who work in intensive care units, and they are certified usually in pulmonary and you know they're you know, so those very sick people, there are doctors there who you know manage that, and the respirators and all of those things. And in some places the hospitalist really is just the triage doctor who calls the specialists. It'll be interesting to see how that all plays out as these fee-for-service reimbursement systems for the doctors shift over to different ways. But it's a great question. Yeah.
I'm interested in your perspective as an educator, as a scientist, and as a physician, on how we deal with the relatively intelligent, well-educated people who are hysterically against vaccination.
Oh, well, you know, what can I say? There are people who don't believe in climate change. There are always going to be, and I mean, there have been from the beginning people who are opposed to vaccinations for religious reasons. But the problem that we got into more recently was fairly educated people, somewhat misinformed, and maybe I think some of it actually was not even a well thought out philosophy that they could explain to you. It was just, I don't want my child to get quite so many shots today. Let's just, maybe next visit we'll do some. I think there was quite a bit of that too. I mean, I think we can educate people. And I'm, you know, in the days of, and actually it's still true actually with tuberculosis. I mean, people can be, I don't want to use the word imprisoned, but they can be put in a hospital, or and they can't go. They got to take their medicines, or they can't go out in the public. Now you know, I mean, schools, the barrier would be to say your child can't come to school unless your child's had these immunizations. I can see schools doing that. Yeah.
I'm wondering, as I'm a relatively healthy person, and I find that my doctors are frequently pushing a therapy of one sort or another, and they don't really understand. I mean, I'm wondering as a patient, how do I help educate the doctor to, as you said, take the hand of the woman and understand who the patient is?
Yeah.
I mean, I've had doctors try and sort of force things down me, and I sit there and say, but I want to be able to hike and be in places where I won't have refrigeration or whatever.
Yeah.
And I leave the room thinking that I'm being not negligent, but
Well, yeah,
like
not a good patient.
right.
You're not a good patient.
And I
Yeah.
don't want to be rude.
Yeah.
But I mean, recently this has come up with 3 different doctors
Oh,
in
my.
this area.
Oh, my.
And I just want to say to them, couldn't you just hear what's important to me rather than whatever pharmaceutical drug person has come to your office?
Right.
So
Right.
how do I become a better patient?
Yeah, you know, and it sounds like you're certainly capable of advocating for yourself, which is the important thing, is you need to, tell the doctor, tell this person what you want, what you don't want, and move on and find someone else.
I have, and
And
they're
I
all
will.
for it. I mean, their response is, we'll have another test.
Oh, good grief. I'm so sorry.
One more question.
Yeah, one more, how about that? Yeah.
What are the significant positive or negative effects of Obamacare that you've experienced from your perspective and experience?
Well, from my perspective, where quite a few of the patients that our clinic was taking care of were uninsured, and so if we could get, we could get some of them, quite a few of them, we were able to get them into Medicaid. It's very complicated to learn how to use these systems, incredibly complicated. So it helped us to, if we could get some sort of insurance coverage for our patients, then we could, I keep coming back to, control their diabetes, their blood pressure. Yeah, I mean, these are, simple things. Get birth control for women. One of the things that we did in our clinic, and it's still there, is we hired a pharmacy technician. I think it cost about $30,000 a year to hire the pharmacy technician to apply to the pharmaceutical companies for free medications, just the expensive ones, to treat the cancer, to treat these expensive medications, to treat our patients. Because many companies have programs where they will, if you don't have insurance and you're poor, they will give you the medicine. And every year we got something, roughly $500,000 worth of free medications from the pharmaceutical companies that we used for our patients. But but for me, more patients got covered. And in some ways, the hospital lost less money.
Thank you, Dr.
Yeah.